we'll demonstrate the push technique. Once the skin incision is made for sternotomy, the electrocautery is used to cut the tissues. The two forceps are positioned in the right hand of the surgeon here. The distal end of the forceps are kept slightly pressed on either side of the incision to retract the skin. Once the superficial part of the subcutaneous tissue is cut, the distal tips of the forceps are insinuated between the two sides of the tissues, and the stem of both the forceps are pushed away from each other using the thumb and the index and the middle fingers. Next, we'll demonstrate the pull technique. To grasp the tissues, pressure is applied at the point of intersection of the stems of the forceps between the thumb and the index and the middle fingers. The thymus is dissected and the pericardium is opened in this manner. The forceps can be inserted parallelly into the pericardium and lifted up to aid pericardiotomy. The forceps can slide over one another while one forceps grasps the tissues and the other protects the underlying structures while making a T-cut on the pericardium inferiorly. This technique can be used to retract intrapericardal structures. This technique is performed using an electrocautery pencil and a carbon dioxide blower mister. These can be interchanged between the right and the left hands according to the comfort of the surgeon depending on the position of the working site. The surgeon is right-handed. A continuous incision is made on the endothoracic fascia all along the lateral border of the sternum with electrocautery. In the blower mister, low-flow carbon dioxide is used and saline flow is kept to a minimum. The dissection is begun at the fifth intercostal space. Using the rubber tip of the mister blower, a pocket is created by teasing movements and separating the lima as a pedicle from the muscle above. The curtain of tissues anterior to this space are cauterized while applying gentle traction on the pedicle with the mister blower. The pedicle is dissected in this manner all along the length of the sternum. The intercostal arteries are dissected using teasing movements of both the cautery tip and the mister blower. They are divided using cautery directly without applying clips. Here, lima harvest is done without the use of forceps. This could be a special advantage in minimally invasive cardiac surgery. The sternocostal muscle is then divided with cautery while applying downward traction with the mister blower. A well pulsatile pedicle is seen. Division of the lima is done as usual. A side-biting clamp is placed on the ascending aorta and a punched-out opening is made. The proximal end of the vein is spatulated and fixed. The left anterior descending artery graft is being anastomosed to the aorta using the parachute technique. The castrovegia is held in the left hand. The needle is passed from inside out on the vein in a forehand manner and from outside in the aorta in a clockwise direction. Once the heel part is done, vein is pulled down on the aorta. Now suturing is continued with the right hand till the 1 o'clock position. Now, the other end of the suture is taken and anastomosis is performed in an anti-clockwise direction in a forehand manner. At completion, the two ends of the sutures are tied together. The second part of the video shows the right coronary artery graft anastomosis to the aorta. The assistant surgeon performed the anastomosis by standing on the left-hand side of the operating table. The castrovigio is held by the surgeon in the left hand. The needle is passed from inside out on the vein in a forehand manner and from outside in the aorta in a clockwise direction. The heel is brought down on the aorta. The anastomosis is continued by suturing with the right hand till the 1 o'clock position in a forehand manner. The other end of the suture is now taken and using the left hand, suturing is continued in an anti-clockwise direction. After completion, the two ends of the sutures are tied together. Aortic cross clamp is removed and the grafts are de-aired.